Today we're going to talk about non-invasive muscle, uh, non-invasive muscle bladder cancer. Now, bladder cancer is staged is basically cancer of the urinary bladder. It can be squamous cell carcinoma or transitional cell carcinoma or adenocarcinoma, and the risk factors are squamous or urachal or non-urachal adeno, which is very rare, and urothelial carcinoma, which is the most common. Now, the thing is that bladder cancer will present with hematuria, UTI-like symptoms. You'll do a cystoscopy, and then you'll get either 60% of the time non-muscle invasive and muscle invasive or metastatic bladder cancer. Now, how do you stage bladder cancer? So, staging is based on this AJCC edition, where you will have a clear TX, where the primary tumor cannot be assessed. T0 is no tumor. TA is non-invasive papillary carcinoma. Okay, it is not urothelial, but it is papillary. Okay, and your TIS is you know urothelial carcinoma in situ. T1 is tumor invades the lamina propria. T2 is the tumor which invades the muscularis propria. T2A invades the superficial muscularis propria, and T2B invades the deep muscularis propria. So this from T2 onwards, it becomes muscle invasive bladder cancer. Until T1, it is non-muscle invasive bladder cancer. And now in this video, we only talk about non-muscle invasive bladder cancer. So let's look at this diagrammatic representation. So this is the bladder wall. Okay, and in the bladder wall, you have the urothelium and you have the lamina propria. You have the muscularis propria. You have the adventitia or the serosa here. Okay, here you have the urothelium, and TA is papillary, papillary projection of TA. TIS is carcinoma in situ. Okay, and T1 is tumor which penetrates into the lamina propria or breaks through the basement membrane. T2A and T2B are muscle invasive bladder cancer, and T2A is early, like superficial muscle invasive. T2B is deep muscle invasive. T3 penetrates through the muscle and into the adipose tissue. T3B penetrates through the bladder and goes through the serosa. T4 invades the adjacent organs, and T4B invades the pelvic organs. So now here the TA is papillary top only. T1 is one step down into lamina propria. T2 is two steps down, that's into lamina propria and the muscle layer. T3 is three steps down, and T4 is four steps down. Okay, and TIS is carcinoma in situ, which spreads on the surface. Okay, and um, now what is low and intermediate and high risk? This is important because your management will be based on this. If it is low risk, simple TA, low grade, superficial is low risk. High risk is shit happens. So C is carcinoma in situ is automatically high risk. High grade and T1 are all considered high risk non-muscle invasive bladder cancer. So that's how we will do the risk stratification and intermediate risk. So now we identified a non-muscle invasive bladder cancer, and now we'll do a TURBT. But what is the management? So supposing it is low risk, okay, then we will give intravesicular. Low risk non-muscle invasive bladder cancer, we will give intravesicular chemotherapy. And if it is intermediate risk and high risk, intravesicular chemotherapy has shown inferior. BCG is not indicated in low risk, but is indicated in high risk carcinoma in situ or T1. In TA papillary, this chemo is better. Now, what is the chemo you will give? You will give MMC mitomycin C 40 milligrams in 40 ml saline. You will give a single dose within 6 to 24 hours post TURBT, and that is and then after that you will give once weekly for 6 weeks mitomycin C. This is the induction of mitomycin C, and then you will give maintenance every 3 to 6 months. You will give 3 weekly mitomycin C for 1 year in TA or low grade bladder cancer. But if it is high grade or high risk CIS, you will give intravesicular chemotherapy. Sorry, you will give intravesicular BCG, not chemotherapy. How will you give intravesicular BCG? Uh, you will you will give it 1 second. You will give it in high risk. You will give an induction protocol where you will give one vial of BCG once weekly for 6 weeks as induction, and then maintenance once weekly for 3 weeks at 3, 6, 12, 18, 24, 30, and 36 months. It's a SWAG protocol. And why give BCG? It acts like a local immunotherapy, and uh, it could have dysuria, low grade fever, prostatitis, systemic BCG infection. And you can give induction BCG weekly into 6 weeks and maintenance BCG at 3 weekly intervals. Same thing that we discussed. 50 milligrams of BCG, one vial. We'll dilute in 50 ml of NS and give it. We'll hold it for 2 hours, but greater than 1 hour, and change position every 15 to 20 minutes. And we will observe it. So that's how you manage non-muscle invasive bladder cancer. You can also use pembro, nadofaragene, and atiso, which is being studied actively. Nadofaragene, aldistiladrin, is an intravesicular FDA-approved gene therapy for BCG unresponsive carcinoma in situ, nadofaragene, which we will discuss later. But overall, this is how you manage non-invasive bladder cancer or non-muscle invasive bladder cancer, that is TA, TIS, and up to T1, but not from T2 onwards. From T2 onwards, muscle invasive, we'll talk next video. Thank you.